We'll probably have some kind of something next week, just so we can read it when I write. See how far we get. Well, this is a good chapter to tell us about how we interview the patient. Anybody, you ever get one over there? All the way back? Okay. Alrighty. It might be a little bit, it might be a little bit kind of over your head, so just a little bit of it, depending on how familiar you are with how pathophysiology works. Back up. Okay. You learn about normal anatomy and physiology. We learn like what the liver does. Okay. As you start learning the pathology part, you'll learn how when the liver starts maybe getting sick or diseased, then the patient could have certain signs and symptoms and lab values. So you'll learn that with each and every organ system that you're going to be scanning. But for instance, the liver. I think I mentioned this last time. The jaundice, the eyes are yellow, the gums can kind of look yellow, the fingernail beds. That's just a sign that something is wrong, causing bile to back up in the liver. So when a sonographer sees that and those elevated liver functions, we think, okay, when I put the probe down, I'm going to be looking for a disease-looking liver, disease process that's going on, or obstructive process, meaning a stone or something blocking the bile from leaving the liver. That either one can cause jaundice. So a lot of this, and you'll see in that the PowerPoint slides and stuff, a lot of it is going to be questions. You kind of ask the patient to get a feel for what's going on with them before you ever start the exam. Okay? So, Chapter 3 will move into like taking blood pressures, the patient care side of things. We started talking a little bit even last week about the first thing we want to do is identify the patient, right? What's something else we want to do with them? Introduce ourselves, right? We want to find out too, have you ever had an ultrasound before? Okay, what if I told you, no, I've never had an ultrasound? Tell them about it. Right? There's no radiation, it's just sound waves. Not going to hurt. Shouldn't hurt you at all, but if it does, let me know. Okay? Your doctor wants me to look at blah, 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 blah. And what was that for? Why do we tell them this is what the doctor wants us to do?
Make sure it corresponds with their symptoms.
Right, that, and also it's kind of giving them a door to say, oh no, you're not going to look at that. Because you got to get their consent, right. So we talked about all that. We want to be very specific in our questions, because sometimes it's like pulling blood from a turnip or what is it? How do you say that? Anyway. You think something really obvious, and sometimes patients won't tell you that. Not just in their symptoms, but you want to ask them, have you ever had any abdominal surgeries? If you're like, say you're doing a gallbladder, or if you're looking in the liver, they sound like they're in gallbladder pain, you want to know if they still have their gallbladder. Okay? Because there's nothing more frustrating than hunting for something that's not there. All right? And back in the day, when I first started, you knew if a patient had had their gallbladder taken out, cholecystectomy, because it looked like they had tried to cut them in half. It was like a half-moon scar over here, like, the subcostal margin, the shape, that's what it looked like. And it did literally look like they tried to cut them in half just to get a little gallbladder out. But nowadays, the laparoscopic surgeries, they'll just have 3 to 4 little bitty tiny incisions. And some people heal really well.
My mom had hers when
and you
her
can't
belly
see that.
button's just a little dark where they went through.
Yeah. And then also we're in a dark room. okay? And I've actually asked the patient, have you ever had any abdominal surgeries? No. They don't know a lot of times what I'm talking about. They don't know what abdominal means. And you might have to get as specific as, have you ever had anything removed from your body surgically? Oh yeah, I had my gallbladder taken out. And then it dawns on them what I'm asking them, okay? So we can't assume, we can't talk medically above their head. Have you had a cholecystectomy? Well, no, you can't tell people that did you what? Have I been to Czechoslovakia? No. You got to talk. Don't make them feel ignorant, okay? Just don't talk down to them, but don't talk over their heads either, right? So this is a real good chapter as far as talking about getting information from the patient and how we need to talk to them. So, let's see. The health assessment is the first thing on your slide. Of course, we're going to, I can't remember what slide we, because I don't like going by slides. I can't remember which one we ended up on. But I think we got through the tips. I'm going to go back to there. Interview process, tips, reassure the patient. We talked about all that. We always call them by name. We talked about verifying that that's who they are. How we're going to do that? Checking their bracelet. Right, their bracelet if they're inpatient.
And their birthday.
Ask them for their birthday. Right. And that's usually, a good way to say, yes, I have the right patient. Because remember I told you I had the man come with me, got all of that department. And it was a very common name, but it was nothing like his name. John, it was like Johnson or Smith. It was a very common name. So you think, well, there could have been two of them. But his name was nothing like that name. He just got up and came with him. I guess so. He thought, well, I'm just kind of jumping on that bus, whatever. But you don't want to do the wrong thing. Jump on them. Okay. We talked about our response to them. Okay, here we go. Health assessment specific to the body structure. This is the part that I said it might go a little bit over your level of knowledge right now, but we don't just look at the order that the doctor's given us and stop there. Okay? For the neck, we're talking about maybe like a thyroid exam. Does everybody know where your thyroid is? Right here. Okay. With a thyroid exam, a lot of times, I don't know if you've ever even noticed the doctor feeling of your neck when you go in to see them. But, they'll kind of wiggle around your neck, and they're usually talking to me, so I'm answering questions. So I'm like, did you check my thyroid? But it's a gland, a paired gland on either side of your trachea, and sometimes a patient will feel kind of like they got something stuck in their throat. They want to all the time if there's a mass there. And this could, most of the time they're benign and everything, but they could cause problems like hyperthyroidism, too much thyroid hormone, or not enough thyroid hormone. And too much thyroid hormone or not enough can be serious. So anytime they feel a mass, we look at it. And then it could be cancer. So sometimes they'll sound like they're raspy, like they're hoarse, if the mass is big enough. So things like that. Do you have trouble swallowing? I've scanned people, though, that don't have symptoms and have a huge mass. So it's not always a true telltale sign, okay? You always want to ask, no matter what it is, how long have you been noticing this going on? Okay? For instance, you probably don't know what a hydrocele is, but it's like fluid collected in the scrotal sac. Okay, the scrotal sac is around the testicle. Testicle's inside the sac. Well, this one patient I had, I'm not trying to be funny, I'm being completely serious. It was the size of a grapefruit, that much fluid in there. And so I'm taking his history. How long have you been having this problem? He said 2 years. I'm like, I want to say, well, what's special about today? Why? After 2 years, I know. How did he walk? Yeah. But anyway, well, then, I kind of thought, well, it must not be cancer, because you probably ought to be gone by now. But it was just fluid filled. But anyway, you do want to know how long it's been going on. You want to say, is it something that like it's pain? not necessarily with moving away from the testicle, any kind of pain. You want to know, does it happen all the time? Is it intermittent? These are good questions that you have to interview the patient on, okay? We have to know this kind of thing. For instance, let me just throw another, I don't like going by these. I'll get back to them. For instance, I'm just kind of giving you a real world kind of sense. A patient comes in with pain in their pelvic area, female patient, okay? First thing we think of is, you know, ovaries or ectopic pregnancy. So you want to know, are you pregnant? That's usually the first one we check off the list. We want to know, have you taken a pregnancy test anywhere? Because if they're not pregnant, we can mark ectopic pregnancy off the list, right? Makes sense. We don't have to look for that. Whew. Okay. Is it pain that came on all of a sudden, or is it something you've been dealing with? It's just all the time pain? Because we need to know, for instance, if it was a ruptured cyst. A lot of women have ovarian cyst that will pop, and it's very painful. It can be very, very painful. Versus a torched ovary, and that's when the ovary is an almond-shaped gland that produces the eggs. Well, it's suspended, like if I was an ovary, on either side by ligaments, okay? And the medial set of ligaments is where the blood vessels come in. They're suspended in the same area, or they're coming into that same area where that ligament suspends the ovary. The ovary can twist up on its pedicle, can twist over on itself. And that's like wringing out a washcloth, kind of twisting up. It'll close off that blood supply. Torsion is painful. But the pain for torsion, it can kind of come and go, but it tends to get worse. Then we look for certain things with ultrasound. But like a ruptured cyst, they might have had some general discomfort, but when it pops, it's severe pain. And typically this is the scenario. They'll have that excruciating pain, like the worst pain they've ever had. And then by the time they're like, oh my gosh, I've got to get help. You know, you're in denial the first little bit of pain. It's like, what is going on? But after 30 minutes or so, you're like, I can't go on like this. You take me to the doctor. Then by the time you get there, it starts to feel a little bit better. That's a telltale sign for a cyst, and it hurts bad for about an hour. But then that pain should start subsiding. It's not going to feel great, but it should start going down on that horrible pain to no pain. It should start going down that little meter. Okay? Torsion or an ectopic pregnancy, the pain's not going to go down. It'll stay or get worse. Y'all follow me? See what's super important for us to interview the patient? You can't just go from, I'm having pain down here. You want to even go as far as say, if you could, with one finger, could you point to the very worst spot and try to get them to pinpoint it? Now, that's not always perfect either, because pain can be referred. That means, like, you could have gallbladder pain, or a patient could have gallbladder pain, but they can hurt back here under their shoulder blade, their right shoulder blade. Okay? My back is killing me. Or kidney stones. My back is just killing me. Okay? So, you know, some people have, now I'm trying to go to some of the referred pain specific I'm going to tell you about. They could say, they could say they're hurting down low. This is a good example. Elderly patients, basically anybody. The older we get, the longer we've been exposed to the pull of gravity, everything goes south, even our internal organs. I scanned an elderly lady, and her gallbladder was down in her pelvis. I mean, everything just kind of went down, okay? And so that's why she was hurting low. It was her gallbladder, but she was hurting really low, not where we tend to think the gallbladder is going to be, up here. So those kind of things, we really have to pay attention. You got to be able to communicate with people. Is there anyone here that's kind of shy when they come to talking? Anybody? All right. Be honest. Okay, you got to get over that. You're going to have to communicate with the patient. Okay, and be focused on them. Tell you what really upsets, especially the older generation, and we could be paying attention. Okay, if we're typing their information in, the patient data and stuff, and we're interviewing them, They want eye contact, and don't hover over them. Sit down eye level and communicate with them, okay? Now, I'm telling you, especially the older generation, if you don't make that eye contact, they think you don't care that they're there.
My grandfather will do that. He'll quit talking to me until I look at him. I'm like, dude, come on. We're
Yeah.
in like 2015.
Yeah. So you gotta be aware of that, because have you ever heard that thing, customers always right? Guess who our customers are?
Patience.
The patients, other healthcare workers, doctors, they're all our customers, okay? So, and there's this, I don't know how big it still is, it's probably big, but there's this initiative that I heard about where there's like customer service and there's like, what do you call them, surveys that they give the patient. And if they're not highly satisfied, it's like the insurance doesn't want to reimburse or something. I don't know if that's true or not, but I've heard about that. Like, But anyway, remember we talked last week about diffusing the situation? That's where the eye contact is really going to be important too, and getting on eye level. And the patient might not be right. They might take something little and blow it out of proportion and make it a huge mountain when it's really a little molehill. But still, it's a mountain to them. You've got to address it that way. At least let them know you hear them. Remember what I said to do? Tell me then. Do you may remember? You kind of regurgitate what they said to
I
you.
hear what you're saying,
Right.
so what you're telling me is,
Right.
stuff like that.
Right. If you, whether they're right or not, and you're not saying, oh, we were so wrong, you're so right. When you communicate back to them, this is what I'm hearing you say, Mrs. Smith, this is, the wait was entirely too long. You might have something in your facility where you can give them a pass to go free lunch in the cafeteria or something. If they're heard, if their grievance is at least heard, that's what most people just want. Acknowledge that I'm a human being and I matter, my time is important, and I don't feel good and I don't want to be here. Acknowledge that. And that'll diffuse a lot. Another thing just on that note, you cannot assume, no matter what anybody looks like, that they are sane. Okay? You cannot assume that.
You work in food and retail, you
Okay. I was a long time ago, before I ever went back to nurse or ultrasound school. Wow, I said nursing. Anyway, I've never been a nurse. But I don't know where that came from. But anyway, before I went back to ultrasound school, I worked at the gas company and took like people's payments. And so we never knew. Okay. And luckily there was like this little glass thing in between us and them. Okay. Because this guy walks up and he looks perfectly normal. And if I'm looking at your account, I have to close like 3 or 4 pages back then out before I can get into a new account. So I said, how you doing today? And I said, give me just a second, I'm going back. And I couldn't even get out of my mouth. He starts literally screaming and lunging like he was trying to lunge over that partition. The little guard had to come over there and talk to him, and I was like, whoa. I'm righty then. I've had a patient punch me.
Oh my gosh.
Yeah, sad she was pregnant. She was from the psych ward, 24, 26 weeks pregnant. I'm doing the exam. She'd had no prenatal care or anything, I think, so they wanted to see where the baby was at and how it looked. And somebody came with her, a tech that works with them, and so I'm scanning, and I'm like, you okay? I'm fine. And I had done it a couple times. You doing all right? And she said, she seemed to be fine. And I'm scanning, all of a sudden, oh my gosh, I screamed. I'm very scared, so you never know. Now, I knew she wasn't saying she was in the psych ward, but, I assumed she was doing okay. Oh, yeah. I was crazy. Where's my 8-year-old? My 8-year-old will go, she's crazy.
Well, I thought maybe you pushed her hard or something.
Or,
No,
she's
like
crazy.
bipolar.
No, I was scared. You did okay, yeah. And the guy that was with her, he was kind of like propped up, almost asleep on the wall.
Of course.
They didn't expect it either.
Like, Miss So-and-so, you can't do that. I'm gonna have to hold your hand. And she went, you better. Ooh. Yeah, baby's good. Y'all go back. We're good now.
They should have somebody in the facility doing that. Like, you should be able to, like, opt to do, like,
No. And now, if you're working for a radiology department, you're gonna scan, if they have a neonatal in your nursery, you're scanning neonates. If they have geriatrics, you scan all the geriatrics, ICUs, CICU, you go everywhere.
Yeah, well, not all hospitals have psych.
That's what I'm saying. If they have psych, you're gonna be scanning them. I've had to go down there, y'all.
Did they give you crayons?
Jello.
Oh, that's another thing. We cannot restrain patients.
Oh my gosh.
You have to have a doctor's order to restrain a patient.
Okay, well, one hit me in the face, the doctor beat it.
Well, no, the tech was there, and he, you know, that was his job to, so he had probably had the orders to restrain as necessary or whatever. But I'm like, they have the little restraints where you could tie them up and everything. You can't tie a patient up, okay? That's against the law. That's kidnapping or whatever. Not kidnapping, there's a name for it, we'll get to it. But, unlawful restraint, probably. But you have to have a doctor's order to restrain somebody, okay? What if a patient came down, I think we covered this already, but what would you do if a patient came down and you told them what was going to, the exam the doctor wanted you to do, and they're like, I don't want that done.
You don't do it.
You can't do it. All right, well, thank you. Yeah. So, that kind of thing. It's just stuff you gotta be aware of and know what you're supposed to do. Now, another thing too, the geriatric end, okay? You have to consider if somebody does have dementia or something like that. Excuse me. Anytime there's a change of atmosphere, like they go to a different room, it's very confusing to them, okay? And do not take words and twist them, okay? I'm not saying that old people are animals, but think about it, okay? If, say, a little dog or a puppy, you come at them, what's their only defense? Right. That's what old people will do a lot of times, okay? That's their only defense. They really think they're in danger when somebody they don't know comes at them, and they'll start thrashing about and hitting and trying to bite you and stuff like that. I don't know if it works with everybody, because I haven't had that much experience with geriatric patients, but ultrasound where I worked was right by New Med, and they came in there and said, can you come help me? This lady will not cooperate. She's trying to bite me, and they had stuff they had to do because nuclear medicine, once they put that radioactive stuff in them, they've got to take the images. You know what I'm saying? So it was like we've already crossed the threshold. We got to do this. So I didn't know what to do, and I got to thinking, well, what would I do if it was a child? You know, so I was staying away from my mouth. But I stood at the head of the bed and was very careful about my appendages and stuff. But I started off rubbing her shoulder and just talking really easy. So you're fine. You're okay. They're not going to hurt you. Just calm this. And it worked for her. She calmed down. And she laid there, you know. But the bad thing about New Med is they take a picture, 15 minutes later, they take a picture, 15 minutes later, and it's a long process. But eventually she calmed down enough. Like I said, I don't know if that'll work with everybody, but somebody that's out of their, you know, I don't say out of their mind, but they're very confused. They can't understand what's going on. Very scared. And they're laying down. Think about, all right, why are we so scared sometimes if we think somebody's escaped from the prison and we're going to bed? Because you're in a vulnerable position. You're laying down. You know, you're not aware, you know what I'm saying? That's a vulnerable position to be laying in, especially if you don't know where you're at, and these people you don't know are coming at you. Big machines, and the room's dark. So, kind of have to put yourself in their frame of mind. Definitely yelling at them or something like that will not help. Be still. You can't do that, okay? Anyway, the cardiovascular system. Of course, if a patient's with you and they start having chest pain, call somebody. Shortness of breath, they start sweating, they turn kind of pale looking. Yeah, you want to call somebody. So this is like if you're doing echoes. You have peripheral vascular disease, stuff like that. Breast. Ask the patient. You know they're there probably because they have a lump. Ask them where it is, and you have to palpate it. Okay? Put gloves on, and you want them to find it, and you want to palpate it. We have to know how deep it feels, how hard it feels, does it move, the whole 9 yards. Okay? They might have to sit up. They're like, well, I found in the shower. You know, I only find it if I'm like this. They might have to sit up and find it. You just keep your finger right there, and then you lay them down, get them in position, and then if it's appropriate, or then you palpate it. Okay? We got to know everything we can find out about it before we scan it.
I have one that it's not one you feel.
Okay.
I have this. Then we got it about a year ago. It's the mammogram comes back with that doesn't work.
Okay, so this is something you didn't know was there. Okay. So in that situation, the patient's not going to be able to help you out much. But you got to look at the mammogram.
It's all
Really?
And my whole mother's side, they all had breast cancer.
Oh my goodness.
Some of them twice. So it's one of those things that any of you girls want to look at it. And you're more than welcome.
Yeah.
It's been over a year.
And repray, y'all be doing breast. So.
For real.
Okay. And encourage them. I always took the opportunity, you know, because when you ask them, do you do the self-exams? I encourage them to do that. Now, I don't do it myself, but, well, when I think about it, I do. But, because the reason is because if they felt the texture of their breast and palpated it around, and next month they're like, oh, that wasn't there last month. You know, they're going to be the first line of defense in catching stuff is what I mean. So, the gastrointestinal system. You're going to have a lot of gallbladder patients that you scan. Okay, you need to know, of course, what kind of stuff have you been experiencing. If they've been experiencing nausea, does it come and go? Have you ever noticed it maybe after you eat? You're like, no, it's all the time. Like when I first get up in the morning, it hurts really back here, right up in here, and I get nauseous. That might be a hernia. Okay, it still could be gallbladder pain, but the reflux and the hernias and stuff, that's a different, it kind of is a crossover with the symptoms, a lot of crossover there. But like gallbladder, if they eat a fatty meal, then they experience that intense pain, that kind of thing. So you want to know that kind of stuff. If you lost the same weight recently, like, yeah, I lost 15 pounds last month and I hadn't do nothing. That's a sign for cancer, okay? Because cancer, all cancers are glucose gluttons. I have to say that's like glucose gluttons. They suck up all of the sugars in your blood. So then, if you don't have sugars for your cells to use as energy, the only other fuel that they have is your fat. Okay, so you just drop weight. It's kind of like somebody that gets diabetes all of a sudden. They'll drop weight. That's one of the signs. But that's the same kind of thing with cancer. Your body's still, the other parts are still needing fuel, and so they'll survive on the fat. Okay, how frequent are your bowel movements? I had a patient come in one time, and they had done a CAT scan. She was having abdominal pain, and they thought they saw, it was an elderly lady, they thought they saw a mass in the left lower quadrant. And with elderly patients, we worry about ovarian cancer and things like that. Well, she just had a big impacted bowel, yeah. So we have to, that's another reason we have to know the anatomy. We don't scan bowel, but we have to know that, so here's your little patient. I'm not a good drawer of arms and stuff. But, you have the ascending, transverse, and descending colon. It's not exactly square either, I know. But then over here on the left, sigmoid goes this way, across that left side, and then into rectum. So this is where she was impacted. I wasn't quite that big, but, so I had to know, you know, I could have showed you right there, okay? See how there's so much bowel in that left lower quadrant? That's where her impaction was. So, I had to know what was sigmoid colon, okay? So, gastrointestinal stuff, you might be scanning a patient, sounds like before you put the probe down after your interview, you're taking their history, you expect to see gallstones. There might not be any gallstones there, but it doesn't mean the gallbladder's not working right, or that it is working right. We can't see function. Yes?
I asked a really dumb question.
And no question's dumb. What is it?
Where is your appendix?
It's, oh, look at my drawing.
Because I don't
come in handy.
over that much.
It's like right there.
Look, really line.
It's like right there. Right as your large intestine starts, yeah, grab the gut. There he is.
Okay, so it's not like this big thing. I didn't think it
It's a little finger-like projection. Here's the cecum. There we go. Hey, look at my drawing. I forget Fred's back there.
Okay, in the ball.
All right. So we're doing a lot of interviewing a patient. The urinary system, I've had patients come in that have recurrent kidney infections they just cannot get rid of. They'll be on medicine, and it gets better, and as soon as they've been off the antibiotics for a couple of weeks, it comes back with a vengeance. You can have a kidney stone lodged in the kidney, it hadn't started hurting them yet, but because it's kind of blocking the flow of urine out, that stasis, what does stasis mean? Standing still, it's not flowing. The stasis of that can allow bacteria to get up in there. It's just like a free-for-all, okay? So that kidney stone was keeping her infection there. So, you know, you never know. It could be that they have had the pain and the stone has left the kidney and it's in the ureter somewhere. So we don't necessarily look at ureters, but in that situation, we would look at the ureter at the kind of, I don't know how much of kidney anatomy y'all know, but this is like a kidney and lung. So the ureter comes out this way, and then it's posterior to bowel. It'll go underneath the bowel, and the ureters come into the urinary bladder inferiorly, posteriorly, okay? As a trigone, yes. So we can't see the space. We can maybe see that much, and then we can go down to the bladder and look for urine jets with McCullar Doppler.
If there's a stone in there, it might be dilated though, right?
Correct. We
Might
look
be
for
more
dilatation, right? Good job. And we look for those urine jets. You have to learn, and you'll see it in repro when you're scanning the bladder in transverse. If you scan all the way, you know, the bladder in transverse looks like that. If you point toward the patient's feet, you'll have vagina, but then look for this little round thing between vagina and the urinary bladder. That's the urethra. Okay, once you found the urethra, that's urine's way out, scan just superiorly, and it'll disappear, and then this posterior side of the bladder, it'll look like there's just little humps, like that, little, very subtle, a little hump, another little hump. That's where the ureters are coming in. So that's where you'll turn on your McCullar Doppler. That's where you know where to put it. And so if we watch and we watch and we watch and we see, you know, we're thinking there's a stone because we see maybe some hydronephrosis or whatever that's backing up. You see jets coming out from the left and nothing ever comes out from the right, and you know it's completely blocked. And that's more worrisome than if there was just a stone making its way and urine was still coming out. Like, even if you see a little urine flow, it's not completely blocked. That's the kind of things they need to know. So you've got to check and go the whole 9 yards. You can't just stop halfway. Why is it 10 yards? It's football season. And I'm thinking, that's the statement, go the whole 9 yards. But anyway, sorry. Must be.
Yeah.
I think Alabama, I think about it. I don't know. Okay, for the repro, you want to know everything about their reproductive history. You want to know, have you ever had, or have you ever been pregnant? Oh yeah, I've been pregnant 5 times. So you know that you get pregnant. Then you want to know, how many children do you have? Okay, you think, well, they just told you 5 times. Well, it doesn't mean that they had the baby. I've had 4 miscarriages. And that kind of, you want to know that history. Okay? Maybe they've had history of recurrent pelvic infections. That's a red flag for us because that can cause scar tissue, pelvic inflammatory disease, recurrent infection after infection after infection. And the scar tissue could stop, if they do get pregnant, it could stop that baby from implanting where it's supposed to be, and it could be outside the uterus somewhere. And that can be life-threatening if it's an ectopic pregnancy for mom. So there's very specific questioning, okay? And so I encourage you, when you're learning about all these pathologies, when, like in this red book, it'll have the clinical signs and symptoms. Pay really close attention. If they say this is the symptom for this pathology, then you need to formulate, how am I going to ask the patient about that symptom? You want to know, you want to get a feel for it. Your interview might be 2 minutes. You might sit there and talk to them for 5 minutes, 10 minutes. It depends on how much history they have. And if you find out that they've had other exams, you need to pause. If it was at that facility, go back. Pull those up and look at them. It's easier now because of PACS. Like, I used to have to go to the file room, pull the jacket. I tried to find out before they came if they had priors. That's what they call them, priors. But you need to look at the priors. Okay? No repro. They need to be performing self-exams too, because they're going to find, same thing like with breast, they'll be the first one, or their partner will be the first one, same thing with breast too. Notice, what's that? Okay? So, they need to do breast exams, men do, because I've scanned male breast cancer before. Yeah. And the majority of the time with the male repro system, they can have torsion too. A lot of times when you're scanning them, it's either a mass or torsion, most of the time. And there's different symptoms. The cancers are usually painless. Okay, torsion, very painful. Okay? There's another thing where, let me see if y'all know this. I don't know how much vasculature y'all did. Where do the gonadal veins drain? Right vein from the gonads and the left. Men and women, gonadal veins.
Internal.
Okay, for which one?
For the left.
The right and IVC.
So the right one goes straight to the
Directly to
IVC.
IVC. Left goes to the renal.
Right, awesome, yes. Okay, think about that. The left venous drainage is called the pampiniform plexus. I don't know who came up with that. Anyway, it drains the left. It has to go all the way up and join up with that left renal vein. Okay, is there anything that pumps venous flow? Or what pushes the venous flow? Well, the valves stop it from backflow. Muscular movements and stuff like that, right? Anytime we move, like our toes, our legs, muscles, anything like that, that's going to compress and push. That's why when you're on a plane ride, or a car ride, they say to squeeze your toes and move around to get that venous flow so you don't get clot. But sometimes there'll be, like sluggish flow on that left side, and that can actually cause infertility because the testicles have to stay a certain temperature or the sperm die. And you might have to scan young men, like 15 to 20-ish age, looking for, well, cancers too, they can get it like in their 20s, but for these dilated veins, okay? If they don't, it's called a varicocele. If they don't get rid of that and fix it, they could be sterile, at least on that side. Okay? So, that Valsalva maneuver I'm teaching you how to do, that's part of it. If it's dilated more than 2 millimeters, those veins, then you have them do Valsalva maneuver. If it stays dilated, then it's a varicocele, and they have to address that. So the specific questions, now with the varicocele, they'll notice pain. But it won't be as excruciating pain as torsion. And with torsion, we look for blood flow, either in the ovary if it's a girl, or in the testicle if it's a boy. Okay? Oops. Musculoskeletal system. We really don't teach that here, but it gives you some questions about it. Endocrine system. The thyroid, they'll be mentioned a while ago. Thyroid symptoms, that's part of the endocrine system too. Can be very vague. It's very strange. It's like if you have the sniffles and you have a fever and you're coughing, what's wrong with you? You got a cold. Thyroid is not that simple. 1 plus 2 plus 3 does not equal whatever that equals. 1, 6. Okay? I mean, it's like crazy symptoms that just don't add up. But, these are all, I know, like, are you hungry or thirstier than usual? Have you been losing hair? See, the symptoms don't add up. Okay? Pulse, 60 to 100 beats is normal for an adult. Respiration, 16 to 20 beats a minute. Normal blood pressure, systolic 100 to 130, diastolic 60 to 80. So systolic is on top, diastolic is on bottom. All right, and we'll learn how to do blood pressures in lab. Okay, this is like I was saying, do you have it all the time? Does it come and go? Can you pinpoint the pain? How long has it been going on? All of this stuff. Okay, any questions about that? All right, let's take a 10-minute break, and we'll finish up the end of this. I put all these slides in here. We're not going to specifically, I can give you the fill in the blanks. I like them because when you go back, or when you get to these individual symptoms, these are kind of little summaries of what the liver does, what the gallbladder does. So it'll be good study stuff. Study 8. Go ahead. What are you after? Start talking again. Another 30 minutes on we go. No, I talked about a runny nose and now mine's running. Sorry. You have to walk around with me. I didn't that till this morning. I felt so bad. We gotta get you.
I saw it. I'm thinking about applying for Home Depot.
No, I got a copy. I'll go get them.
Because this gig was something at the warehouse. Behind the warehouse.
They covered that.
Where was you? Is it over by where you said? I don't know if I'm gonna stay over there though. Anyway, I'm gonna get that snack. It's a good company to work for. Good job.
His test is excruciating.
Oh, yeah.
Yeah, we only have 2 tests and midterm problems, so if you do horrible on the test, you're just gonna be dead.
That's what it feels like being midterms already.
Yes.
Don't you get the retake one at the end of the semester?
I think that's
That's
Birmingham over
true.
to my
That's
hand.
true.
Oh, because you
But
ain't
I'm
out
just
just
gonna just like legally get,
Go
legally
for it, girl.
get most of these, most of these.
All right, bye.
It's like, we only covered half the 39.
Yes, and then the other ones is a free fall, you just have to
It's
learn.
like, well,
He's gonna be on the.
Read ahead, she.
it's like we covered the chapter.
I thought it was some classes that were going on.
You're used to the 4-hour one. Yeah. I know.
We got to cover a whole lot more.
I know. It's crazy for me too, because it's hard
But
to
it's just hard to
transition.
study it because it's like, what is this even talking about?
Yeah, and it feels like we
These
have.
first 2 chapters are not super specific. They're giving you a lot of overall information.
No, we're talking about training.
What are y'all going over?
The,
Neonatal,
yeah.
uh,
Well, we were kind of behind, so
Yeah.
39 is pretty long, and we went over it like 20 minutes.
Yeah,
They
we
read
spent
it, and then half of it, we had to go over it by ourselves, and then we're having to test on it, and I'm like,
Okay,
wait.
what part do you not understand? I can help you with it real quick. Is it
Y'all
the
get the
ligament?
slides, you put all the slides online.
Yeah.
yeah, 'cause that's what I got my
That helps a
phone.
lot, that was just like I stayed in the,
Look at that pretty
and,
picture.
she went over it, and I was just.
I need a new,
I'll try to
It
find
wasn't that bad. I mean,
I'll try to find you one.
No, I wanna get my own when I get a stable and stuff.
Walmart has them.
Okay.
I guess this one, it came with a lanyard, and you take the lanyard off just with this, it's like $4.99.
Yeah.
Oh, that little Z's outlet up on the hill, the same one with big lights and all that, you know what I'm talking about? They have lanyards.
I want to elevate it personally.
And now I told them most of it's only getting Yeah, and we haven't even done those
Alright, what you hunting now, tell me. Yeah. What is it? The muscles or what?
It's just that confusing to me. And I don't know a lot about it.
Tell me where to start and I'll give you a crash course.
All of it. It's on this chapter.
Step away from remember the muscles.
It should be right on top of yours.
I understand like the cycle and all that.
Okay? The ligaments and stuff, is that what you're having a hard time with? Okay.
Because we've never.
Alright, well, when you're talking about the pelvis, like look at this guy right here. I think her little uterus and stuff comes out, so that'll be good. Alright. I feel like that's the orifices. There's muscles. Oops, I just dropped her something. Her baby. I dropped her baby. Okay. There's muscles that hold everything up inside you. Okay? We call that like the pelvic diaphragm. That's a rectum. That's the vagina. I need one more thing. Rectum, vagina, and urethra. The pelvic floor muscles hold all that up. Okay? So it's like your coccygeus and iliococcygeus and pubococcygeus and all levitator anti-muscles. Ever seeing those? Levitator
Those like in the
anti-muscles.
phone.
Yeah, there's 3 of them.
Yeah, 3 of
First
them.
floor.
The levitator anti-muscles. Okay? There they go. That's like, this image is like if you cut me off right here and you're looking down. No insides at all, you're seeing what's holding everything in. See that urethra coming through vagina? Like this, coming up through the muscles. Okay? Some people, the muscles get weak and their uterus can actually slip down and prolapse. Start trying to come out the vagina. Yeah. So, okay, so you got the pelvic floor muscles. And the reason we gotta understand that they're there is because you don't want to confuse them with an ovary. Because a muscle in long looks long, but in transverse, it can look like an ovary. Okay? Another thing to keep in mind, like this drawing right here, like that's one. Look if I do that one. Oh, there's the, figure 39.
No.
See the blue line?
Whenever I'm talking about like,
That's like cutting the patient in two and looking at it. The peritoneum is wide on here. It's gonna go posterior to the bladder, see where it scoops back up, anterior to the uterus, it goes all the way around the uterus, and about the level where the cervix meets the vagina, it'll scoop back up and cover anterior to the rectum. It's like a saran wrap lining, covering everything. So we gotta be aware of that ovaries are intraperitoneal. So if you're scanning the vagina in trans, you might cross one of these muscles and go, oh, that looks like an ovary, there's my ovary. It can't be an ovary, because the ovaries are intraperitoneal. They're not going to burrow down in there, okay? So where the cervix and the vagina meet, from that point superiorly is where we look for ovaries, okay? Also, if you're scanning, that would be the way you're scanning through and looking at it, posterior to the uterus, the only organ posterior to it is the rectum. Okay, there could be fluid that collects in this little pouch right there. See the pouch? Pouch of
Douglas.
Douglas.
And then you
Called
got
the cul-de-sac. You can
Yeah.
call it the recto-uterine recess.
Between the rectum and the,
It's like recto, recto-uterine recess right there. But a little bit of fluid in there, fine. A lot of fluid, something's going on. Like an ectopic pregnancy or cystis rupture or bleeding. Okay? Not fun. Okay? You should never see fluid anterior, in the anterior cul-de-sac. That makes the pouch too. See how this uterus is anti-flexed? Like this would be how it was in the body. It folds this way, most people. Not anti-burden. So vagina is always going to be a 45-degree angle, and then that uterus usually cocks over, like a 90-degree bend. Yeah, folded up on itself. Okay, they can flex forward, they can flex backwards. The cervix, you can feel it. The cervix can go.
I don't understand it.
Oh, right. See, let me take a picture.
Oh, yeah, cool.
So there's your bladder. Okay, vagina. We'll draw cervix in red. The cervix will go, like most people, in the antegirded. This way, making that 90-degree angle.
Like, explain the picture, she just
Okay,
like,
it could go.
I'm like, yeah. And there's like a little.
Oh, you should get it That's really no version at all, really, though. It could really be retro. I've seen when they go.
Worried about that. I was like, I have to go to the doctor for things.
And then mine just go up.
I mean,
I got all different things. It's not the cervix, it's really pretty much fixated, the cervix won't move. Uterus continues to walk around it, it's wrong. It's not fixated. Well, not like that. I've seen people say, well, my uterus was retrograde last quarter, yeah, that's why I got retrograde. That's what we were talking about, my bladder was perfect the first week, and then last week, Graham came in again, she said, did your bladder move? You probably have, is this supposed to, a big bowl of boo-boo pushing it over. Yeah, I know, you can have.
Good morning.
It'll put more
Good morning.
Are you okay with the ligaments? How are things supported?
Oh, I need.
no.
That would be a negative. That was my worst last quarter.
On the uterus.
I hate those ones.
Here we go.
The round ligament is going to take, and from the fundus of the uterus to the pelvic side wall. Patients that just get pregnant, sometimes they'll have round ligament pain, because that uterus is growing this way, and it's still attached, those ligaments have to stretch like rubber bands. Okay? In that same area, remember the saran wrap, the peritoneum? that's what we call the, broad ligament. Because as it wraps over, it's got edges. Like, think if you're wrapping a piece of chicken up, it's gonna have those little wings out to the side, you usually fold them in. Looks like the peritoneum. The part of the peritoneum that wraps over the fallopian tube, mesosalpinx. The part that wraps over the ovary, mesoovarium.
I hope we're this good at this stuff.
No.
Cause I mean, I still feel like.
Well, it's new to y'all, but, and don't compare
Oh, I know,
yourself
but
to
it's
us.
just kind of scaring me.
A lot with the muscles.
Yeah, it's just scaring me, I guess, cause we're going on clinicals next quarter and I'm still trying to learn ligaments and stuff.
Well, yeah, you let them know this is my first rotation. I've only held the probe for 11 weeks. Okay, another thing too, when you're scanning, if you think, oh, is that an ovary? I can show you how to find ovaries lickety split if you're having trouble with ovaries. If you're thinking, is that an ovary? You've got to learn the skill of turning on it without losing it. Okay? Practice that. Because if you turn on something and it lengthens out, like, it's a muscle.
Is there like stages in clinicals, like to start out with, are we gonna be like, could you go to a hospital where you have a broad, like your first one, like a broad range of different?
No, that would be in an ideal world, and it would be great if we could do that. But the first rotations are just to dip your toes in and get your feet wet.
Well, that's
And
fine,
see
that's
what's
what I
going
was
on.
worried about though, because I didn't know what they were gonna like, expect, yes.
That's why you have that conversation with them. And you don't have to say, I don't know nothing. Okay? But you can say, you know,
That would be the professional.
I'm like a
way.
green stick right now. I am brand new, and I can't wait to learn everything you can teach me while I'm here. You know, I'm not super confident. I've never worked with patients, never been in a hospital setting. Let them know. Okay?
I think that's how much I was about.
You'll be fine.
Going in there.
The thing about it is, y'all, the clinical rotation experience is what you make of it. Okay? What you're supposed to do if you get served a lot of lemons,
Make lemonade.
make lemonade out of it. Twisting their eyes, no, I said, too quick, no, you can't do that.
Margarita?
After,
Okay.
like, kind of getting on the road. Okay, but what I'm saying is, y'all, the rotations that I went to, I didn't get to scan hardly any, and it's just unfortunate. Sometimes they'll spend time with you, sometimes they won't, okay? And we can't, y'all, we're guests in their facility, we're not paying them.
Do we have to get permission from the patient, like, I'm a student, is it okay if I watch, or if I'm in on?
Usually the tech handles that part,
Okay.
okay?
Yeah, sort of like a doctor when they bring you in.
Right, because it, yeah.
What?
In the ER at Shelby a while back.
Cool. Were they good? Job professionalism and stuff?
She's quiet. At CBA in Birmingham, Oliver's home here. Also,
How long does it take our students?
I have no clue.
Now, Mike is super nice, he did my thyroid, and he said to say hi again, and he is super nice and explained everything. Of course, I told him I knew y'all, and I was in
Yeah.
school, and he's showing me everything.
Yeah.
He was really nice, he really loves his job.
Is there any way we could just throw?
Mike Nixon?
We go.
We,
Yeah,
right
Five
along
years.
here.
I've heard a lot of the other
He
students
travels
say they
around
had
to different
clinicals
clinics,
and they were kind of.
and they give him a car.
You know the
He
first
said
scrotum
they
I
give him
understand?
all of his insurance.
On the job.
He said he loves.
Okay, sometimes you just do what you gotta
Curious
do.
to see where they
Okay, you learn the anatomy. The only difference between a thyroid and a scrotum is there's a thing called the epididymis. And
There's a newer
that,
version.
hemiuniform plexus.
It
you have
didn't
to
seem
look
like the
for.
ones we had, but I can't tell if it's newer than the
The
newer.
first full
it's newer
OB
than the
scan I
old.
did on a patient.
He said it was a.
A lot of my first were on patients. The first breast I did was on a real patient. Now, do I tell them like this is the first time I've ever done it?
Oh, little bitty guy.
No, I acted like I knew what I was doing. It might have taken me an hour.
Tell her.
What hospital did you
They
say?
didn't know it.
She said to me that they hired somebody.
Oh, that's all. Yeah.
And he was so like,
Pregnant
one
women
minute
on
on Tuesday.
Who did?
Miss Able.
And he goes every day.
I was asking
Or
her
every
about the OB,
Tuesday.
how we, you know, about
You know what I mean?
people not coming in, that is, I mean, people coming in
She said
pregnant.
we hired somebody.
She told me this Wednesday, she said they hired somebody to go out and actually seek people out so they can come in when class is over.
No, I think what she's saying is they hired somebody to come in and like sit with us and like help like
walking lab, I guess, or something like
No,
that.
that's,
I have no idea what y'all are talking about. I don't know.
So then they sent she said they sent someone out to bring in.
yeah, that's what she told me.
I haven't heard of it.
But they can come here to get
I like that, like, we're gonna get like
Yeah.
a hoodie or something,
that
he
already
said, like,
is.
a
Well,
matching.
I mean, that's something we could talk
I
about.
think that's
too.
that'd be nice.
Yeah.
Can
I
we
mean, I
all
was
in
just
favor?
giving an idea,
That's
because it's
I like
just,
that. Do y'all like that?
you know, they see everybody wearing the same thing every time they come. Won't that look more professional than everybody having, you know,
Like,
Yeah, that-
pretty color.
and you might not think about it, but that's part of the professional thing, is like, you wouldn't wanna wear a hoodie over your uniform. I mean, or
We
like
could
a
wear it in class.
pullover sweatshirt.
Yeah.
And you don't, like, what, Emily has on, that would be fine, wearing just a plain fleece, or what Larry's got on. Yours is just like a cardigan, you know, I mean, what's yours got on? It's got some writing on it.
Yeah, it's AirPods.
Yeah, so we probably wouldn't wanna wear something like that, even though it's fine for here.
Only
You know what I'm
problem
saying?
would
Try to
be,
look polished.
like if we do, but it's like, talk about color, cause this teal, I mean, like the uniforms we get from the
Uh-huh.
school and the ones we can order different, there's
Yeah,
so
we
many
could get the
different
same
types.
Well, I would probably stick with something like gray, white, black.
Yeah, it's great, oh my God.
Yeah, white would probably get done real easy, so gray would be good. Like a charcoal gray, about like your, sleeves, Malia.
Yeah, that'd be
Yeah, I
good.
like that.
I'm just throwing ideas out there, but, and even if it didn't have the hood, like if it was, I don't know if y'all seen the jacket that I've got, one class ordered, it just says ultrasound on the back. They did it in hot pink though, but I'm saying still, if I were y'all, I would come up with something very classy
Yeah.
and professional looking. Not a huge emblem on the back, maybe just something right here. You
Something
know.
Larry could wear.
I'm just,
Not
you know.
pink.
Fuchsia,
Yeah.
powder blue.
Well, you're right.
That's great. I'll take it.
Yeah, like red, white lettering,
Yeah.
and maybe a little burst of teal
Yeah.
in it or something.
DMS
Just something that
or
looks
something.
very classy and professional.
I think that's
Um,
nice.
You know, and not super expensive, because everybody didn't have $40-50 to drop on a jacket, you know? But anyway, it's just an idea.
That's a good.
That way we all look the same when we go,
Mhm.
you know, it's in the code of conduct. Like here, we're a little bit loose on like long hair, but you want it pulled up neatly. You know, you don't have to necessarily put it in a bun. If you're comfortable in a bun, keep it in a bun. But, you know, the way you got your hair right now, Rebecca's perfectly fine. But you don't want to drag it through, you know, if you're reaching over a patient's skin, you don't want your hair dragging through the gel or their cookies and stuff, you know. And you don't, like if a patient starts to fall, you don't want them to grab your hair and, you know, you're not going to be able to help them much if they're taking your head down first. Okay? The big hoopy ear-ending knees you wouldn't wear. Okay, it's very, you know, understated. If you think understated, like, I know that's trendy, the black, but when we get to clinicals, no. I mean, older generation, they look at black and they think, devil worship or something. No, I mean, it's just what it is, yes ma'am.
What about a ring?
I would probably just wear something simple like this. I would probably take my engagement ring off. Because, like this one, the older people get, the thinner their skin gets. And they can barely just bump into something like this, and their skin rip and
Well,
tear.
see, my actual engagement ring, like it moves a lot, so it sometimes ends up underneath.
Yeah,
But my wedding band, it's.
yeah. You might just want to do that. And then also, the less jewelry you have, the less chance of getting germs up under there. You know, I mean, I know you want to keep your wedding band on, but, I would do minimal. Plus, what if you got to put gloves on? Like, see, I couldn't work in that, because I'd rip every glove I put on. Sometimes you don't have time to put them on slowly and carefully. You gotta get them on because something's going on. So, I would keep in mind that kind of stuff. Oh, another, just a word to wise, since we're talking about clinicals, I know we're not there yet. They're gonna be coming to do the shots, it's the first or second week in November.
I've got one.
Hepatitis.
Good. So I need a count. I know we told you we had to like You had to like week 5 or something, what did Miss Hester tell y'all?
Pretty quick.
Week 5? Get them in as fast as you can, because I need to give them a count. I need to know how many people need CPR. I gotta get all that stuff.
So the shots are gonna be, what shots are coming?
Okay, so, like, if you,
MMR.
no, if you've already had your MMR, that's what you're bringing
Right,
proof of. Like, if you can't find them, worst case scenario, we'll have to get titers drawn. But that can get super duper expensive. We all can't just jump on that boat, okay? I mean, I'm talking about, like, there's absolutely no way you've done everything, you cannot find them. That's
And
when we'll
what's
have
that
to-
one that they have to test us all for?
Everybody will get the TB.
Okay.
It's like a little tiny needle prick under your
It's not-
skin,
Okay.
and they feel like a
I
little
just know they
bubble
have
of
two
stuff
different
up
ways
under
to
it.
do it, so I didn't know which way they did it.
It'll be in the skin, and then, so they'll come on a Friday, we'll have a clinic day is what they call it, it's a new company coming, and then they'll come back on Monday to read those. So you have to be here.
Are they giving out Hep C vaccination?
Not C, but B.
B.
It looks like I only had one hepatitis B shot. Was I supposed to have more?
It's a series of 3. You'll want to get in touch with your physician and ask them what you need to do.
Hepatitis A is usually the one you end up not finishing.
But,
I'll
any
look
questions
through
like
the
that, ask your family doctor or your, whoever you go to. We can get the physicals done here, okay? So like, if you have insurance that covers your physical, if you can go ahead and get it done on your own, that would be awesome.
Okay, what kind of, like,
I'll give you a form. It's just a base, it's kind of like, you know, when people are playing sports, they're like, I need a sports physical. It's like that, but you're like, can I do ultrasound physical? You know, it's like, basically, our creditors say that we have to have some kind of proof that you're physically able to do this job.
okay, and I have one last question. Like, when we get the drug test, I guess it'll be whenever, what do I need to do about my medicine that I actually take? I'm on Adderall, so it's...
I don't know how they do that. It doesn't have anything to do with us. You can let them know, like, when you're going in for the drug screen, they'll do that here too.
I just didn't know
It's
if I
like
needed my
a-
medication.
Yeah, no,
Prescription.
Yeah, but I need,
yeah. I think what the
if I needed an
protocol is,
actual-
I could be wrong, but I think what the protocol is, if something shows up, even if you told them ahead of time, they call you and they say, so-and-so showed up, and you say, well, I have a prescription. They say, who is the doctor? They call that doctor, they verify the prescription, you're good. That's what I think the protocol
Yeah,
is.
because some places will want to see the actual prescription, some places will ask for a medical list from the doctor.
I have no idea. Because it's a new place, I don't know what they do. Yes, Larry, you have, I thought it's on hand.
I was just
Good?
gonna say
Okay.
something still.
So everybody,
Not you.
I need your shot records ASAP. What does that mean?
As soon as possible.
That means
I
yesterday.
get mine recorded today.
Okay. All right, and if you have CPR, do like an American Red Cross issue, American Heart Association, not Red Cross, Heart Association, 2-year CPR that's still gonna be valid through the end of your school, then that's fine. I just gotta have the card.
When will we get that if we do not?
This quarter, we'll be doing CPR. And be prepared, y'all. Like I said, the clinic day is a Friday, okay? This is the warning. This is the fair warning. Either the first Friday or the second Friday in November. It's like the 9th and it will be the 16th, I think. They haven't told me exactly the day, but keep in mind, write it down, say these 2 Fridays, I don't need to schedule anything super special going on, but I can't be here. Okay? CPR won't be that day. That'll be another day.
Friday, 6th or the 13th of November, it looks like.
Oh, 6th or the 13th.
That's what it looks
Okay.
like, if it's the first or second.
Where I got it.
9th is a Monday.
The gift, those.
So, the 9th's a Monday?
9th's a
That's where the
Monday.
9th, because they'll come back on the Monday to check your TB screen. Okay, so those 2 days, well, you'll be here on Monday anyway for class. But Fridays, that you're gonna have to be here, that one of the first 2 Fridays in November is what it's looking like. When I find out for sure, I'll let y'all know as soon as I find out. It is, it's a yearly thing, you have to get screened for. So, she asked about the TB.
I have, so I wasn't sure if it
Yeah.
was still good over the yearly.
So you're gonna be providing me with or Ms. Abels, with your shot record showing you've had the measles, mumps, rubella. If you have varicella vaccine that's on there, great. If you know you've had the chicken pox, you didn't get the vaccine, there's still some that have, been that route, okay?
Your blood and support, and then they'll write it down with you, because I've already had to do that one.
Okay, so you still have proof of that you've done that?
I can probably get my, doctor to write something.
Yeah. There you go. You just get something legitimate, official kind of proof. Worst case scenario, if we end up sending you somewhere the only place you have to have it is children's, and we can get the titers, or you can, whatever. We just need to know ahead of time. Usually what I do, unless somebody specifically said, I don't have it and I want to go to children's, then we'll go and get your titer. If not, I just look who's brought the proof in, and those are the people that get the hat, pulled out of the hat to go to children's. Okay? Oh, the hepatitis B series. Again, that'll be the shots you have to start the series for here if you haven't already had it. Okay? So we're looking, we've got to have the MMR. Everybody's had that. If you went to a public school, you had to have had it. And then the physical, if you have your own insurance, it's not going to cost you anything. Just go ahead and get it done. I can give you the form. Yes.
What about flu shot?
Flu shot, we're trying to get them to give everybody the flu shot too. A lot of places are saying you have to have it, or you have to do they call it an attestation. It's like a statement saying, I'm, never going to get the flu shot. I'm against the flu shot. It's against my religion, whatever. I'm allergic to eggs. I don't know what the excuses are. You have to have a statement saying you're not going to do it. Okay?
What does that prevent you from doing again?
Nothing, they just have to have a record. Something's going on where they have to have a record of everybody, whether they've had it or they denied it. Or like they said they're not going to get it. I really don't know what that does for them, but a lot of hospitals are moving to that. You're what now?
I don't believe in them. I don't think that they just generally help, but I have to get it.
We're not forcing y'all to get it.
Right.
No, you're fine, we were on break.
I forgot.
How'd it go?
Well, they wouldn't give some day unless their car, how that goes.
Oh, yeah. But the other place.
That's what Rachel's at.
Roseanne, that's right. Remember I said I thought that was the osteoporosis and imaging? Yeah. Yeah, she didn't want to take one. I've been trying to.
But last year.
Why did she just call us?
Got the flu, and then they released a statement.
I don't think it's
They
anything
take
wrong
all
with
the
the virus, because if she can't be there, they have to just walk together and they're tired of it.
I don't believe in that.
That's kind of what it is. Anyhow.
All righty. Okay. So, everybody knows what we need to do?
Yeah.
Yeah. I mean, and just put forth a good effort, and we have a backup plan if you can. We just can't do titers on everybody.
Oh, I'm gonna find as much as I can, I don't like any.
You know what I mean? Yeah. But everybody knows what they need to be gathering, right? You may be what they need to be gathering.
Okay, so we do need a physical as well?
Yeah, and it's not like you have to do a CBC and all that. It's just basically, like for instance, okay, and this girl had a physical too. She had her physical, but she tells us, we had a student that told us like in her third rotation, getting ready to go to extern, can you send me somewhere that I don't have to be on my feet a lot? Like, she had
Another career.
a familial disease that runs in her family. If she stands on her feet too long, the bottom of her feet blister.
Bless you.
Oh.
Well, that's something you need to know before you go into a program like this. Y'all, I can't tell you when I ever sat down. You know? So,
Why would they tax her?
should I be dealt with?
Probably where she got that too.
I don't know.
So we need to have the physical done by?
No, just by next quarter.
Okay.
But like what I was saying is, if for some reason you don't have insurance, or if they make you pay for your physical, like with mine, I can get something like that like once a year, and my insurance will pay for it. Well, our insurance just changed. I might be lying. I don't know. My old insurance would pay for it.
My new insurance that much.
So, but if you're like, well, it's going to cost you $150, then we'll just do it here.
Okay.
So I'm saying,
Okay, so.
That, we don't just don't, what I'm trying to say is that we will cover it if that's what we have to do. But the more expenses we add on, the higher tuition goes up. So, I mean, you know, we're just gonna try to be frugal and prudent with the way we use the funds that are available.
Plus with the new machines coming, definitely.
Yeah.
Did they
They're
decide on
there.
doing that?
They're still entertaining close.
Well, they're not cheap.
No, no, it's a pretty penny.
Well, we sell the old,
$7K a month.
we sell the old stuff though.
But they're leased out, aren't they?
The four of them. The IU-22s are leased. Yeah, we're not gonna get rid of those unless we get new.
Yeah, we can sell them.
Well, that's part of, hopefully for DG, it's a trade-in thing. IU-22s are back, we trade in the old, they give us new. So, it'll all work out. But anyway. I just wanted to throw that out there because that's coming up. It'll be here before we know it. I mean, November's like clicking at our heels. Yeah.
My mom at lunch today, I'm like,
Exactly. Okay, this is the slide that I was telling you about, if you want to fill in, because I did do the blanks in this one. So this is like page 21, that's not page 21 on yours, let's see, page 8 on yours. A minute, maybe not page 8. Yeah, it starts on 7. If you want to fill in, that one doesn't have any blanks, but the next slide does. Portal Venus system, just so you have to fill in the blanks. Because these are really good, like I said, to go over each system as you're learning them. Kind of, you know, little extra study guides here. So the Portal Venus system brings that nutrient-rich blood from the intestines to the liver. So we talked about, I told you about that in physics over and over and over again, right? You learn that in anatomy. Hepatic artery supplies nutrient-rich blood to the liver. Through the porta hepatis, that doorway in. And that's just where it comes in. Biliary system drains. Okay, then you got the next slide, there's a couple, I didn't mean to do that, fine. All right, let's see, bile pigment removed from the blood by special hepatic cells, called, I want to say Kupffer cells. I need to double check that, because I took the little things off for myself, too. We get back to the liver. Where's that liver? I just don't want to lose y'all straight. Like I
Is bile
said,
pigment all born out blood cells and materials derived from vagus's removed from blood by special hepatic cells.
yeah, I was right, Kupffer. Tell them what that thing is doing when I spell Kupffer.
In the first, like right at the end of the paragraph.
Oh, okay, it's on there anyway? Oh, it is on the next little thingy. Okay. Deposit in the bile that says bile. Okay. Any more blanks? Yeah. Okay, the bile flows into the bile ducts. And then, common bile duct is what takes the bile out of the liver. I like these last two. Well, I just like this whole system. The bile duct joins the pancreatic ducts where it enters the duodenum and ampulobator. And there's a sphincter that controls it. It's not on there, but you know what that's sphincter of Odie.
Odie, yeah. I think
That reminds me of Garfield.
Well, I think of Obi-Wan Kenobi and Darth Vader.
Okay. But it, you know, the little dogs like Obies. And then that helps you remember about the gallbladder systems. I think, well, Garfield likes to eat lasagna. Lasagna's greasy. Anyway, sorry. I think about food a lot. Okay. There it is. Sphincter of Odie relaxes bile, small bowel. And cholecystikin is the enzyme that causes the gallbladder to release. 60K is what they call it. If you're having a HIDA scan, the nuclear medicine study to see if your gallbladder's functioning. Remember a minute ago I said we might scan the gallbladder and there'll be no stones, but it doesn't mean it's not, it might be working. Yeah, so.
Like a gallbladder.
Mhm. So they'll give you like a, it's like most places give you an egg sandwich, and inside the sandwich it has the CCK, and it causes your gallbladder to contract, and they can check to see if it completely ejects all the bile or not. And that could be just because the gallbladder's just not working right, and that may be what causes some of their pain.
But why do they give you that hormone?
Because they want to force the gallbladder to squeeze to see if
But I
it's
thought it
moving all.
releases if you eat anyway.
Well, I guess they wanted it to be in control, because it should if you eat anything with fat in it, but I don't know, it's just they want to.
We wouldn't be able
Make
to
sure.
tell though, because we wouldn't be able to see them all together.
Well, we wouldn't be able to see it functioning. Like, I don't think mine functions really well, because I let people scan me and I'm eating breakfast, eating lunch, drinking coffee with creamer, and my gallbladder's still big.
Mine was like, I was the only one that people could see my gallbladder.
Yeah, we live in the gallbladder or gallstone belt, y'all. We live in the bile belt and the gallstone belt. Yep, and I'm prime candidate, female fat number 40. Those are the 3 F's, female fat 40.
I'm with you.
That's what it was in my book when I was a student. It's probably not politically correct now.
It is what it is.
It had a picture of a little grandma looking fat lady. It was a drawing. Anyway. Okay. Try to get these for y'all real quick.
Oh, yeah, that's.
The pancreas is the exocrine and the endocrine gland. So the exocrine means that it has ducts, okay, D-U-C-T-S. Endocrine is ductless. So the insulin side, the alpha, beta, and delta cells that produce insulin and the insulin inhibitors and stuff, that's the endocrine side of the pancreas. Exocrine, sorry, I forgot to set her up. The exocrine side is what produces the pancreatic enzymes, the juices. Insert, twist, I'm just kidding. Okay? And that endocrine is the islets and Langerhans. I didn't make that a blank though. Any more blanks? Last one's blank is on the kidneys. The last little blanks you have, this one can give you the fill in the blank. The nephron is a functioning unit. Glomerulus and renal tubules, you'll be learning all about that in scanning 3 classes. Okay, as far as testing stuff, it's more going to be on the patient history, on that whole little spiel we did on all of that, not these individual, like, I'm not going to test you on the gallbladder, I'm not going to test you on the kidneys. You know, I might ask you stuff like, which of the following would be a good question for somebody that you're expecting to have gallbladder trouble, and you kind of pick from the above, or pick from the choices. You know, more on that side of things. I just thought those were really good because it'll help you when you're going back learning those things, little study guides.
Do we have a test next Monday or something?
Yeah.
On 1 and 2?
Go ahead and do 1 and 2. I haven't made it yet. So, yeah. Yeah, and y'all keep it